So let me introduce now Dr. Manisha Acharya. She is a senior consultant, cornea and refractive surgery services. She is the medical director of the Eye Bank at the Dr.Shroff's Charity Eye Hospital, Delhi. And she has to her credit a lot of awards, the British Medical Journal South Asia Healthcare Award. She had a travel grant by the European Eye Bank Association, numerous best free paper poster awards. And she has also authored a book released by the Eye Bank Association of India on the eye bank recovery technique. So over to Dr. Manisha Acharya on HSV.
Thank you very much. I'll start my screen share. So am I audible and the slides visible?
Yes, ma'am. We can see the slides and hear you well.
Thank you. A very good morning and very good evening to respective participants and the esteemed faculty. At the outset, I want to thank the Scientific Committee AIOS for making this possible, and it's a great scientific fiesta, especially Dr. Somshala, for all the efforts you've put in. And it's very difficult to speak after Professor Chodosh, but I will try to present two cases which I have managed in my practice. So HSV, we all know that presents maybe like an epithelial dendrite to potentially blinding, necrotizing stromal keratitis. So we've seen all the presentations in the previous presentation. So this 13-year-old child presented with complaints of diminution of vision and pain and redness in left eye for the past 3 months. The symptoms had subsided with treatment with oral and topical acyclovir.
I'll do that. Okay. Can you see me now?
Following discontinuation. On examination, the right eye was essentially normal, but the left eye had...
I wasn't speaking. I said, why disturb people with my video?
Mute your mic, please.
Yeah.
No mind. Admin, can you mute Dr. Maskati?
So the corneal involvement actually showed this multiple epithelial bullae in the center. You can see that disc which is forming with the stromal edema. But there was the anterior stromal infiltrate which was measuring around 1 to 2 millimeters and keratic precipitates which were present on the endothelium. So we started this patient on acyclovir 5 times a day and prednisolone eye drop 4 times a day with homeotropine and a tear substitute for 4 times a day. A corneal scraping was done from that area which was having an infiltrate which was denser. But the smear examination was essentially normal. But GIMSA staining showed multinucleated epithelial cells going more in favor of the viral etiology which we were suspecting from the beginning. The RT-PCR for HSV 1 and 2 was negative. The reports definitely came a couple of days later. 6 days later, with the treatment, the patient had a mild response. So we stepped up the steroids further to 6 times a day and continued the rest of the treatment. By 10 days, the patient was improving, and by 3 weeks, the patient had significantly improved with clearing up of the edema. The acyclovir tablet was then reduced to 2 times. Prednisolone eye drop was continued in tapering dosage now, and CMC again continued. 6 weeks follow-up, the patient doing much better and was then continued on prophylactic oral acyclovir 400 milligram twice daily and was asked to follow up 3 monthly. The patient did well with this prophylactic dose and was quiescent for 6 months. But despite being on this prophylactic acyclovir, the patient again presented with this epithelial dendrite. It was started on the topical antivirals and did recover. I'll take you to another patient, which was a 46-year-old male and had this very classical geographical ulcer. Was started on acyclovir eye ointment 5 times, a homeotropine and a CMC eye drop. 1 week post-op, the patient had started to definitely respond with blunting of the edges of the ulcer and was continued on the same treatment. But 2 weeks later, there was this deep infiltrate which has come up, which was not there previously. And with that, there was this dilemma which came up. Are we dealing with a stromal necrotizing or a stromal keratitis, a combined association, or a superadded infection? For this, we did scraping, which turned out to be negative for bacteria or fungus, and we stepped up our treatment, start adding oral acyclovir 5 times a day, and along with the topical, which is already on, and also added steroids in the form of prednisolone eye drop 4 times a day. And within a week, the patient started to respond. At that point, we reduced the steroids and tapering dosage, and also the oral acyclovir to 2 times a day. The prednisolone was also put on tapering dosage and a very slow tapering dosage, and later on the patient was continued on low dose steroid, which is a load in a form of Lodex, which we get in. So I would like panel's view in knowing what is the prophylaxis protocol for recurrent cases, as the patient, even on the normal dosage, just a 13-year-old boy did recur on oral acyclovir. And also your call on long-term topical steroids or anti-inflammatory therapy in recalcitrant cases. So thank you very much for the opportunity.